Hello, and thank you for joining another episode of Health Equity Matters. I'm Vik Bakhru, CEO of Nzinga Health, and I'm joined today by one of my favorite people, although I think I say that on every episode, perhaps. So I'm joined today by Nzinga Harrison. Nzinga, why don't you introduce yourself? I can't do it justice.
Yeah, Dr. Nzinga Harrison, good to be here with you, Vic. I'll start with I'm actually his favorite person, despite what you've heard on previous episodes. Just kidding. Dr. Nzinga Harrison, co-founder and chief medical officer of Eleanor Health. We provide equity, harm reduction, and trauma-informed care in a population health reimbursement model for people with substance use disorders and other mental health conditions. I'm a physician and my board specialties are psychiatry and addiction medicine. Most importantly, I'm a wife and I have two teenage boys, 17 and 15, soon to be off to college.
That's amazing. Congratulations on especially that last part.
Yeah, congratulations on the teenagers. Not for the faint of heart.
A lot of work. Yeah,
yeah,
exactly.
they're great. They're great.
They'll be back, give them 5 to 7 years. Don't worry.
I know. Well, it's funny. My husband established very early, you can come back anytime and stay as long as you want. And I was like, did we align on this messaging before we started? But I'm fully there. I'm fully there. You can come home anytime and stay as long as you want.
That's great. That's great. Well, we have some serious topics to talk about today. You and I had a chance to compare some notes before the episode, and I think some of the issues that you raised are of critical importance to our current ecosystem, not just from a health equity lens, but from an outcomes lens. How do we actually improve outcomes in a value-based world when we're talking about very sensitive issues that involve a lot of trauma from the past? And so let's maybe dive in from the standpoint of trauma-informed care. How do you view it? How do you define it? What is your framework for assessing it? Teach us.
Yeah, so trauma-informed care is a really well-developed concept with SAMHSA leading the way and lots of other really important organizations jumping into the knowledge base. And it basically starts with this concept. When people think about trauma, they think of rape or getting robbed or a car accident or a natural disaster. All of those things are true. I mentioned I'm a psychiatrist, and the diagnostic manual that we use to guide our diagnosis is the DSM. And the DSM-4 defined trauma in a very narrow way that was basically like you had to either truly be about to lose life or limb or believe you were going to lose life or limb. And that very narrow concept just handcuffed our ability to appreciate all of the different types of traumas that people experience. And so trauma-informed care says there are 3 E's of trauma. It is an event that is experienced as physically or emotionally harmful, that has long-lasting effects, negative effects on mental, physical, psychological, or spiritual well-being.
Yeah.
And when you take that bigger definition of the 3 E's, I know we're here talking about health equity, then of course, that lens clearly includes racism, discrimination, oppression, marginalization, and all of the ways that we do that to people and communities in this country. I think none of your listeners would refute the idea that racism, discrimination, oppression, marginalization are a series of events that are experienced as psychologically and physically harmful, that have lasting negative consequences on our health and all of those domains mentioned.
Yeah, I couldn't agree more. I don't think anyone would deny that, but I wonder, how do people perceive it? How do we train a workforce and educate those around us to perceive it correctly? Because it expresses itself in many different ways. The underlying trauma may manifest in not the ways you might expect. There might be certain behaviors or attitudes or other attributes that you encounter as an individual, as a clinician, perhaps, that maybe you're not sure how to read the signs and how to make the diagnosis, even perhaps in this case. Diagnosis.
I'm so sorry I jumped in. I was like, yeah, I was being your amen corner. I was like, yes, because You're so exactly right. And so if you think about the way even we just talk about people from the healthcare system, we talk about being non-compliant, and we
Mhm.
talk about being ungrateful, and we talk about not wanting to be healthy, and we talk about the bad choices that people make, right? And it's all pretty punitive and
Absolutely.
denigrating,
Absolutely.
um, and really pinned in a lack of understanding for what people are dealing with from their past, what people are dealing with in their present, the priorities that they're having to navigate. And so you really gave me this beautiful segue into the 4 R's. So, like, this is what I want your listeners to walk away with: 3 E's,
Okay.
4 R's, 6 principles, right?
Okay.
Um,
Okay.
and you can Google it and you'll be able to drop into it pretty quickly. And this isn't only for healthcare. This
Yeah.
can apply to no matter what life you're living, what professional, you know, thing you're doing. This can apply. So the 4 R's are exactly start with what you said, Vic, which is one, we have to realize trauma is the rule, not the exception.
Mhm.
So the first R, we realize the widespread impact of trauma. Two,
Yeah.
we recognize what trauma looks like. So for example, at Eleanor Health, we have our core four. Our core
Okay.
four is equity,
Mhm.
harm reduction, trauma-informed care, and then the fourth one is teamwork, which is the easy word we chose for collaborative care model.
Sure.
And we're, you know, talking about harm reduction and trauma-informed care. And one of our clinicians brought up a case of a community member who would keep all of his medication appointments, but
Mm.
he would miss all of his therapy appointments. So your traditional way of thinking about that is, one, he doesn't want therapy. Two, he's not compliant with the treatment program. Three, if he doesn't get better, it's his own fault because we recommended therapy and he didn't come, right? But
Yep.
once you listen to his story, the first time he had ever been to therapy years ago, first of all, it took him 35 years to go. He
Yep.
finally goes to therapy at a recommendation and uncovers a significant set of childhood memories around very terrible physical and sexual abuse that he had suppressed. So not repressed, like he knew it happened, but he had just pushed it far enough back for it, he thought, not to be affecting his day to day. And so
Yeah.
when we're asking him to come to therapy, we're asking him to overcome the trauma of going to therapy. It's not just that he's no showing,
That's
he's
fascinating.
actually trying to get there, right? And so recognizing that his no show is a symptom of trauma,
Yeah.
recognizing that when a person yells at you may be a symptom of trauma, recognizing that when a person becomes volatile may be a symptom of trauma,
Yeah.
recognizing all of the physical and mental and social manifestations of that. So that's the second R. And then what you're really talking about, Vic, is third and fourth R's, which is okay. And so how do we respond to that? And
Mhm.
that is longer than 15 minutes together. But
Well,
to
we'll have a
quote
part two. We'll have
to
to do a
quote
part two.
the amazing organization of AA and NA, the
Uh,
first step is recognizing,
yes. Yes.
right? So
Uh-huh.
like first we're going to recognize trauma is ubiquitous, all of the different ways it can look like, and then responding by fully integrating that knowledge into our policies and practices. And then the fourth R is the most important, which is resisting re-traumatization.
Mm.
And so you think about all the ways, and we're talking about health equity. So that's why I'm keeping my comments kind of narrow to health, even though it applies to
Yeah.
every system
Absolutely.
in our lives. You
Yeah.
think about all the ways we re-traumatize people during their most sick and vulnerable times, when what they need is compassion and warm arms to wrap around that vulnerability to create a sense of safety.
Yeah.
If we're not being intentional about not re-traumatizing, then we are re-traumatizing.
Yeah, yeah, yeah. And I want to use that as a jumping off point because, right now we have initiatives to open up EMRs to allow individuals, people, patients, members to view their information, which is absolutely the best practice in the right direction. But it doesn't feel like we've done a lot of retraining of how to document in a way that doesn't traumatize through the just process of daily work, right? The workflows that we follow today, and in some case, the terms that we use. If you look at, there was a study done, I believe, I think it came out last year, and it was talking about how, and it was examining how clinicians perceive race in the context of health, and how I think it was 2.7 times or 4 times, somewhere in that neighborhood, the negative verbiage associated with Black individuals as opposed to their white counterparts. And it was the same clinicians, and the study did a really good job, I think, of highlighting. And so now in this era of, open EMRs and people being able to access their information, how do we address the trauma that comes from perhaps stumbling across information where the person you may have sought out for care, or that you were attributed to by a health plan perhaps to receive care? How do we address that? Because there's so much to teach, I think. And when we talk about trauma, all the various R's that you just mentioned, getting to that next step is hard. That is not easy.
100%. I think this is such an important call out, because you're right that it is a switch from understanding that the information in that chart belongs to the patient. We tend to think of the EMR as belonging to the system or belonging to us as the physician, and no, it is that patient's EMR. And there is a way to document things in a way that is not harmful. Again, first, it starts with understanding your own implicit biases, is what you're talking about, right, Vik? Because you're not going to look in the chart and see the N word. It's not going to happen. It's not going to be explicit like that. But what you're going to see about a Black man versus a white woman is that a Black man was hostile and angry, and a white woman was upset and visibly disturbed.
Yeah.
Right?
Yeah. And this we got to fix.
This we have to fix, because I just grabbed very quickly. I was looking at a similar study yesterday, Vik, about discriminatory language and negative language towards patients in EMRs. And it is harmful because we'll get into the 6 principles of trauma-informed care, but the first one is psychological safety.
Absolutely.
Right? And so when I read my chart for a person that I am entrusting my most vulnerable insecurities to, which is my health, and I see you talking about me negatively.
Absolutely.
I can't believe anything you tell me. I cannot follow any of your recommendations. I'm probably not coming to another visit with you. I thought I could trust you. I already didn't trust the rest of the system. I thought I could trust you, and now I've been betrayed by you. Certainly not going back to the system. This compounds to the health disparities that we see in different communities. And so, even just for example, we are language militant at Eleanor Health for this reason, right? And when I'm training medical students, residents, other people at Eleanor Health, we always say, write that chart as if the person is going to be reading it. And so it's the difference between, this is a 27-year-old unwed, unemployed mother. Now, factually accurate. Right. But the stigma that is driven in that sentence, when I could as easily write, this is a 27-year-old mother who doesn't have a partner, is caring for her kids without support. And is looking for employment, which has been difficult to find. I told the exact same story without vilifying or carrying implicit stigma against that woman.
Yes. And what is so disorienting and concerning is that this is actually baseline. This
is our training.
This
is our training, Vik.
Right. And so, I didn't wake up one day and think of these terms. This is a system in which I was educated to perform against a certain standard.
That's right.
And we've got to now redefine that standard. We've got to do better.
Totally. Take that even one step further. For people that may have a hard time understanding the concept of structural or systemic bias and racism, this is what we're talking about. So when we are being raised up as medical students being trained, if I had said, this is a 27-year-old woman who has never been married, is currently raising her kids without much support and looking for employment, which has been difficult, my attending would have said, you took too long to tell me that. And would have corrected me to 27-year-old unwed, unemployed mother.
Yeah. In fact, the emotional attachment to the verbiage was something you excluded from your anecdotes.
That's right.
Absolutely.
That's right.
Yeah. So we have so much more to cover. Clearly, we're going to need a part two, but
Okay, I would love a part two if you'll have me.
but bring us home with some of the other principles I think you wanted to share.
Yeah, definitely. So, and we won't go in depth, but this will make sense to your listeners. So remember the three E's, a series of events experienced with negative effects.
Yeah.
The four R's. One, we realize everybody has trauma. We recognize the ways that can show up that we don't expect. We try to respond to that and we resist re-traumatizing. The way we resist re-traumatizing is by thinking through these six principles in every individual interaction, in every program procedure that we write, and every systemic policy that we develop. Number
Yeah.
one, safety, physical and psychological.
Yeah.
Without safety, there is no relationship upon which health can be built. Number two, trustworthiness and transparency. So
Mm,
that goes to safety, right? If I don't know what you're thinking, then I can't feel safe. And that goes to how we document in the chart. Document in the chart as if you're talking directly to me, so that when I read that, there's a trustworthiness and transparency in our relationship. Three is peer support. You cannot design for people without having their voices at the decision table,
yep.
period. And when people have been through something similar, they can support each other in a way that
Mhm.
is different and more effective. Number
Yeah.
four, collaboration and mutuality. So, medicine is so vertical. Healthcare is so vertical. I
It,
trained, so I know what I'm talking about. So
mm,
here's what you need to do. And
yep.
if you don't do that, that's on you.
Yep.
And if you had done what I said do, you would be better. So I don't want to hear that you're not better, right?
Yep.
That is vertical and ineffective. You
Yes.
really have to horizontally partner. And this
Yeah.
is individually programmatic, systemically,
Yeah.
understanding the competing priorities, the value sets, the goals from that person, and designing to that.
Yeah.
Empowerment,
Hmm.
voice, and choice. We
Um,
have to put people at the center of their care.
yeah.
Your voice actually has to be louder than mine. Now, this is difficult for the long white coat. This is difficult. Your voice has to be louder than mine. And then finally, cultural, historical, and gender issues. So interestingly, Vic, when these first came out, it was three E's, four R's, and five principles.
Oh, okay. Yep.
And
Yep.
number six, which is cultural, historical, and gender, is a new addition. So we're growing, because how
Yeah.
is that new? Because that should have just been there in the first place.
It should
But
have.
we're growing. Now we know that's to how we started, which
Yeah.
is trauma-informed care. We established racism equals trauma. So high school math, A equals B, B equals C, A equals
Mm,
C,
yes.
right?
Yeah. Yeah.
Racism informed care is
Mm,
trauma informed care. So how do we get to that?
that's amazing. I am inspired by you continuously. And I just thank you so much for joining today. This has been an amazing session. I can't thank you enough. I've learned just so much here, and I'm sure our listeners will appreciate that as well. So thank you. And
This was
we'll
so
see
fun.
you, we'll see you on again in the future.
I'll see you again, Vic. You promised me part two, so
Yeah, I promised you a part two. Everyone's our
trustworthiness and
witness.
transparency.
Oh, yeah, you know it. Absolutely. Well, I can't thank you again enough, Nzinga. This has been an incredible session. I've learned a tremendous amount. I'm so glad that we had a chance to connect. We will absolutely connect again here in this forum at some point in the not too distant future. And I thank you to our listeners for joining another session of Health Equity Matters. I've been joined today by Dr. Nzinga Harrison, Chief Medical Officer and co-founder of Eleanor Health. And I'm Vik Bakhru, a physician and CEO of Innovista Health Solutions. Thanks again for joining, everyone. Until next time, take care.